This video is about secondary hypertension. We're going to cover the advanced organizer to help you remember the causes of secondary hypertension, triple HARPCO. But unlike in endocrinology and the surgical hypertension lessons from third and fourth year, this is not going to focus as much on the pathways or the full workups. You needed to learn that for your shelf, and you're going to need to learn it again for your boards. But when it comes to actual practice, that doesn't make much sense because you could always look it up. It's never going to be an emergency to look up what studies do you need for secondary hypertension. And the reason for this is if you've gotten to this point where you're like, I've done all the right things and this guy is still super hypertensive, and because the testing is so inexpensive and non-invasive, it doesn't make sense to not screen for all the things. If you've got a good review of systems and you remember things like hypertension and central obesity, Cushingoid, or hypertension and hypokalemia, Conn syndrome, good. If you spot it, you make it great. But the thing is, people can have those diseases and not have the classic vignette. So you're going to do this in anybody who has more than 3 medications, who's compliant with those medications, and still is not under control. You get onto the 4th med, and that's when you think, man, what is going on here? Because it's probably more than just essential hypertension. It may still be. And some people say, wait to the 5th med, but after you get to 3, start thinking about it. And then when you get here, you say, okay, well, I'm going to do all the things. And we'll cover what that is. If any one is positive, you continue. And for each positive screen, you go down the path for that disease. The mnemonic, the advanced organizer, is triple HARP company. That is 3 H's, HARP, CO. It stands for hypercalcemia, hyperthyroid, and hyperaldosterone. It is actually primary hyperaldosteronemia, a tumor that secretes aldosterone. The A is a little bit of a cheat. It's aortic coarctation. R is renovascular, which really means secondary hyperaldo. Which also means end-stage renal disease. The only thing the kidneys retain the ability to do as they die is make renin, which means it's really hard to control end-stage renal disease blood pressure. P is pheochromocytoma. C is Cushing's. O is obstructive sleep apnea. Daytime somnolence, snores, wakes up, partner, I always say. Cushing's, moon phases, central obesity, diabetes, hypertension, buffalo hump. Cushing's. Pheochromocytoma, 5 P's. Renovascular could be fibromuscular dysplasia or an old gut atherosclerosis. It could be anybody. Aortic coarctation we'll spend some time on. In pediatrics, if they have it so bad that they can't walk because as soon as they leave the crawl phase, they have such terrible claudication that they won't walk, that child is not going to make it to an internist to be diagnosed with that as the cause of secondary hypertension. You may find this person because they got a chest x-ray and a radiologist saw the rib notching. But chances are the coarctation is not going to be so severe that they get claudication or they look like they have PVD. Most people who have decreased pulses in their ankles compared to their wrists, or have problems with their DP and TP pulses relative to their brachial artery, have peripheral vascular disease from smoking, hypertension, and diabetes. If you feel cold legs, don't jump at coarctation of the aorta. But if they have resistant hypertension, it's something you should then go after. Hyperaldosteronemia, hypertension, hypokalemia, almost never actually seen in real life. Hyperthyroid, Typical symptoms: tachycardia, palpitations, weight loss, diarrhea. Hypercalcemia can be anything. So I wanted to say those out loud so that you know that you did learn those for a reason. And yes, if you happen to spot one of those things and they have hypertension, you're like, oh, I can predict that my screen may be positive, but you're still going to screen. You get a BMP for a calcium. Make sure you include an albumin to correct. You get a TSH and a free T4 for hyperthyroidism. You get an aldo to renin ratio, and you're looking for it to be high, greater than 30, in primary hyperaldosteronemia. For the aortic coarctation, you're going to get ankle brachial indexes, but be careful because that's probably peripheral vascular disease. And you'll get the chest x-ray looking for rib notching, but don't go crazy after this disease because chances are it's not going to present for the first time in an adult. If for renal vascular hypertension, you're going to get the aldo to renin ratio again. But because you're going to get a 24-hour urine for these other diseases, you might as well collect the 24-hour aldosterone. For pheochromocytoma, the best way to do it is a 24-hour urine for metanephrines and other catecholamines. Cushing's, because you're getting the 24-hour urine anyway, go ahead and get a 24-hour urine cortisol. The right way on the exam to test for this for Cushing's is to do a low-dose DEXA scan. And there's some other ways to screen for it, but it's easier to send the patient to just pee in the thing, collect their urine, and go get some labs, rather than having to come in, get a shot, get checked in the morning. That's less logistically challenging. Since you're just doing all the things because you've hit a box, do the things that's easy for the patient. And only pursue that if they really do look Cushingoid. For obstructive sleep apnea, sleep study. This video is simply to show you that I have a cool mnemonic for secondary hypertension, and to remind you that in real practice, if you get to the point where you need to do something about secondary hypertension, do all the screening things, because they don't cost a lot, they're not difficult to do, and you can get a lot of information out of it. That is secondary hypertension.